honor none other than Dr. C. Sarath Kumar sir. Let me share some of the achievement of sir. Sir has done MBBS, Diploma in Medical Radio Diagnosis, DRCOG, Special Distinction in Obstetrologist, Super Specialist in Infertility at Dr. Sarath Men's Clinic, Director at Mediway Fertility Research Hospital. And today sir is going to speak on a topic trans vaginal scanning for infertile women. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you. Thank you, Faroz, for a nice introduction. Good evening, doctors. Sorry, I am late by, I think, 30, 40 minutes. I was held up in the traffic, Bangalore traffic. So I was forced to be delayed. So I request you to pardon me. Okay, I will start without wasting any time. So today's topic is role of transvaginal ultrasound scanning in the evaluation of male patients with infertility. Just to introduce the subject, they review the technique for assessing the antral follicular count, follicular measurement, sliding sign, and explain the follicular endometrial assessment intrauterine for intrauterine inseminations and for IVF cycles. So the chapters I'm going to cover are introduction, in indications for TVS, equipments and personnel, preparations for TVS, uterus, endometrium, ovaries, adnexa, cul-de-sac, and conclusion. So different type of ultrasound scanning. So baseline scanning or screening of ultrasound is done by pelvic anatomy of the uterus, including uterine lining and bilateral ovaries. All abdominal findings or abnormal findings are measured and characterized, such as fibroids, uterine malformations, hydrosalpinx, and ovarian cysts. Follicular monitoring ultrasounds are used to track follicles that are maturing and measure the endometrial thickness and also note the endometrial consistency. Transabdominal scanning is also required because there may be some huge fibroids which cannot be covered by the transvaginal scanning. Hence, before doing the TVS, routine transabdominal scanning is indicated. And indications for TBS: baseline assessment of uterus, ovaries, adnexa to rule out any pathology like fibroids, polyp, uterine abnormalities, hydrosalpinx, PCOS. Ovarian reserve assessment, antral follicular count, monitoring ovulation, timing of the ovulation for triggering during IUI and IVF, assessment of endometrial thickening for IUI and IVF, for performing oocyte retrievals and sometimes embryo transfer and other uterine procedures. Transabdominal scanning is effective. So why TVS is more important than the transabdominal scanning for ovaries and uterus is because the transducer will be very near the organs. We go almost touching the uterus, touching the fallopian tubes, for touching the ovaries, so that the organs are seen much better. The resolution will be far superior. And also to do some procedures, for example, for oocyte retrieval, the transvaginal scanning is the method of choice. So indications for TVS are much more than the indication for transabdominal scanning. And equipment used is, of course, ultrasound equipment. But only thing is the transducers are of higher megahertz, that is more than 3.55. Nowadays, even 7.5 and 10 megahertz scans, transvaginal probes are also available. So even now, right now, 3D scan and color Doppler scannings also have come to the market. Before scanning, for transabdominal scan, the distended bladder is recommended to displace the bowels and provide acoustic window to visualize the pelvic structures. However, for TVS, no full bladder is required. In fact, if it is full, the patient may have some inconvenience when we put the transducer. So half bladder or quarter bladder is enough for TVS scanning, and also for SSG, sonosulfongogram, an empty bladder is recommended. Personnel, of course, should be a radiologist or a gynecologist well trained in the ultrasound and also in the reproductive endocrinology and infertility specialists. These are all the people who are qualified to do the ultrasound scanning. And of course, as per the PNDT Act, taking the license to do the scanning is very, very important. Though you may not be doing OB scanning, still to do the transvaginal scanning or any other scanning, as per the PNDT Act, taking license is very, very important. Even if you are qualified, even if you are MD Gynec or MD Radiology, you have to take a license. Technique: the patient is kept in dorsal lithotomy position and TVS probe is introduced into the vagina either by the patient or the sonographer. Transducer is covered with ultrasound gel and a condom or a condom-like cover placed over the gel probe. Very important thing is gel has to be put inside the cover also. That is inside the condom also. That is on the head of the transducer. Gel has to be put. Otherwise, the air gap will be there between the transducer and the condom, and you may not see the image properly. And gel has to be put over the condom also. KY gel or similar gel is placed on the cover transducer for patient comfort. And if there is pain, you can use even xylocaine gel. Uterus is evaluated in both sagittal and transverse planes. Attention is given to evaluate the size, shape, and orientation of the uterus, cervix, myometrium, and endometrium. Length and height of the uterus are measured in the sagittal plane. Width is measured in the transverse or coronal plane at the level of the tubal, ostia, or coronal regions. Myometrium is evaluated for any pathology like fibroids or adenomyosis. Location and character of all pathological lesions are noted and documented. That is about the uterus. Endometrium goes through consistent changes each month in response to the hormonal milieu. After slotting the endometrium and in response to rising estrogen, endometrium thickness significantly increases during the follicular phase and shows trilaminar pattern on ultrasound. After ovulation, the luteal phase, the lining becomes decidized, brighter, and is unilaminar and until menstruation. The menstrual endometrium can have heterogeneous appearance with hyper and hypoechoic features. So that is about the endometrium. And endometrial thickness, the endometrial morphological changes and vascularity are assessed while performing ultrasound during natural or stimulated cycles. Endometrial thickness of the endometrium is thin initially, that is 4.4 plus or minus 2 mm after menses, but it increases up to 10.3 plus or minus zero point 0.3 mm before the ovulation. That it reaches the maximum size of about 13 millimeters on in the mid cycle. In natural cycle, the mean endometrial thickness ranges from 10 to 12 millimeters before ovulation. Morphology of the endometrium morphology can be categorized into three patterns: trilaminar, homogeneous, and heterogeneous. A trilaminar endometrium is triple layered and characterized by hypoechoic endometrium with a central line. This pattern is noted during follicular phase from 5 to 6 days before ovulation and continues to the day of ovulation. The presence of a trilaminar endometrium on the day of trigger injection has been associated with higher pregnancy rates in IVF cohorts. Once ovulation has occurred, organized appearance of the trilaminar lining disappears and endometrium becomes more homogeneous with poorly defined outer walls and absence of the central echogenic layer. Assessment of the endometrium. Endometrial assessment includes measurement of the endometrial thickness, identifying endometrial morphological pattern, and grading the endometrial vascularity. To assess the endometrial vascularity, color flow power Doppler is required, and you can measure the endometrial flow and few seconds on the endometrial layer occupying 50% of the screen. During assisted reproductive technology, that is ARTA cycles, that is IVF cycles, it is often sonographic clue before laboratory confirmation that patient may be ovulating. A heterogeneous endometrium may be seen while patient is menstruating due to presence of blood or clot when intercavity pathology, that is polyp, myoma, or hyperplastic tissue is present. Endometrium is measured perpendicularly from one echogenic to other echogenic border at its thickest part in the mid-cycle plane. If the fluid is visualized in the cervix, endometrium is measured by combining anterior and posterior endometrial thickness separately without including the fluid. Endometrial vascularity is classified into three grades based on the visual assessment of endometrium on power color flow Doppler imaging before ovulation. Grade 1 shows no subcutaneous subendometrial blood flow. Grade 2 shows subendometrial blood flow. And grade 3 shows endometrial and subendometrial blood flow. That is about the endometrial vascularity. Ovary, based on stages of development, the ovaries are primordial, primary, secondary, tertiary, and antral follicles. The number of primordial follicles determine the true ovaries reserve. Primordial follicles are small and difficult to be seen in the ultrasound. Ovary has got 6 to 7 million primordial follicles at around the 5 months of gestational age, slowly declining to approximately 1,000 at menopause. The ovary with the initiation of menarche, a cohort of dominant primordial follicles are recruited during each of the menstrual cycle, and these follicles grow in size steadily. These primordial follicles develop into primary, secondary, and antral follicles. Development of the fluid-filled cavity, also called as antrum, adjacent to the maturing oocytes, results in forming the antral or tertiary follicles. In normal cycle, one follicle matures and is destined to ovulate while the other follicles degenerate and ultimately disappear through process called as apoptosis or apoptosis or programmed cell death. That is, in other words, each lady of reproductive age in each cycle she produces one dominant follicle and sometimes rarely two dominant follicle if there is no stimulation. Of course, in stimulated ovarian cycles, there will be multiple follicles. The ovaries are identified bilaterally and measured in three dimensions, that is, length, height, and weight. The antral follicles are seen round or oval anechoic structures. A baseline antral follicular count is performed by counting number of follicles between 2 to 10 and measuring the dimensions of follicles greater than or equal to 10 in the early follicular phase in both ovaries. Antral follicular count can be measured using three different techniques during the transvaginal scan: a traditional real-time two-dimensional scan, stored 2D sine laws, or three-dimensional 3D data sets. Real-time 2D scanning is used to measure the ovary in both longitudinal and coronal planes. Next step is to optimize ultrasound settings for better image quality while centering the ovary on its largest axis. Ovary should occupy at least 50% of the screen while count is done. Follicles ranging from 2 to 10 from ovary margin to the other. Total follicle number of both ovaries are added to the antral follicular count. Antral follicular count, one of the standard measurement for ovarian reserve, is calculated as a sum of all the follicles ranging from 2 to 10 contained in both the ovaries. The preferred time to measure the AFC is during the day 2 to day 4 of the menstrual cycle. The absence of corpus luteum and ovarian cyst should be eliminated. Even though there is slight variation in the AFC during menstrual cycle, the AFC can be performed at any point during the menstrual cycle as long as cysts are not obscuring the view of the ovary entirely. Follicle stimulating hormone, that is FSH receptors, are developed in the antral follicle once it reaches a minimum of diameter of 6 and further growth of this follicle is under control of FSH produced by the anterior pituitary. Dominant follicles are follicles above 10 by day 8 to day 12. Dominant follicles are usually are formed and they grow at an average of 1 to 1.4 diameter per day until reach a mean diameter of 20 to 24 millimeter at the time of ovulation in a natural unstimulated cycle, that is 2 to 2.4 centimeter. Well, coming to corpus luteum, for ovulation triggers, most IVF centers usually use the cutoff of 18 to 20 before the egg ritual. This differs from the patient to undergoing the clomiphene citrate cycle, in which the recent literature suggests follicles closer to 21 to 22 have a higher odds of leading to the clinical pregnancy. After ovulation, follicle collapses to form the corpus luteum, producing progesterone and estradiol to support the implantation of the nidation. Corpus luteum has a ring of fire on color flow due to large increase in the angiogenesis. That is, the corpus luteum, in a nutshell, corpus luteum is the aftershoot of ovulation. Monitoring ovulation during ovulation induction cycles, TVS is performed. Follicle assessment, already have told, the 2D or 3D images are done. Coming to adnexa, adnexa is evaluated for any mass such as hydrosalpinges, paraovarian cysts, and paratubal cysts. Cul-de-sac is evaluated for any fluid or sliding sign is performed to assess any additions. Examiner hand is placed on the abdomen to apply the pressure on the uterus. TVS probe is placed near the posterior vaginal fornix to assess whether the cervix and the uterus glide over the anterior rectum and sigmoid colon. The lack of sliding of these organs implies adhesive diseases of these structures. So, coming to the role of ultrasound in embryo transfer, transabdominal ultrasound is usually used to guide the embryo transfer catheter during the embryo transfer. An increase in pregnancy rate of 30 to 36% was noted when embryo transfer was performed during ultrasound versus the clinical touch method. So, friends, to conclude, ultrasound is safe, reliable, cost effective, and easily available imaging modality to assess the anatomy, morphology of female reproductive organs. Performing 2D ultrasound and 3D ultrasound in one sitting can curtail the significant time delay in performing the infertility workup. Performing a 2D ultrasound is part of the general OB-GYN training, but performing 3D ultrasound generally needs additional training. All general obstetricians, gynecologists, and radiologists are not equipped with this special skill. Therefore, collaborating with a REI provider or physician who provide fertility services is important to provide care in timely and efficient manner. Patient care coordinators and nurses also play a crucial role in managing infertility patients and during the transvaginal scanning. Timing of ultrasound is typically precise to the patient's menstrual cycle. Therefore, scheduling patients for ultrasound expediently is essential to an infertility evaluation. So that's about the role of ultrasound in the management of infertile women. So the webinar is open for discussion. I request if there are any questions, I'll be very glad to answer. So once again, sorry for the delay. Over to the moderator. Over to
Thank you
Feroz.
so much, sir, for giving your valuable time and sharing your knowledge with us and making this
Thank you.
session informative one, sir. I definitely
Yeah,
think this session knowledge is going to help all the participants who have joined. We totally understand the traffic of Bangalore, sir, and we know that you have done justice to this topic. Sir, moving forward, I can see still we have received after the delay also we have some questions from the participant as they were waiting for this webinar, sir. It was really
yeah,
great, and I want to thank the participants also for their patience. So the question is from Dr. Subramaniam Sagar. He's
yeah.
asking, can you share any interesting or challenging cases where transvaginal scanning played a crucial role in diagnosing and managing infertility?
Yeah, hundreds of cases are there where it was very challenging to diagnose also. Many times, only when we do TVS, huge fibroids may be missed. In fact, if you just go for TVS only during the assessment of infertile lady, you may miss a fundal fibroid, which has become an abdominal organ. What happens is the depth of the transvaginal scanning, the organs which is seen is limited to about only 12 to 14 centimeters. Beyond that, you are not seeing because the resolution is so high, it is limited. Maximum, say, about 5 6 centimeters. Beyond that, hardly we see the organs. That's why a general abdominal scanning is routine scanning is indicated before going to the 3 TVS. The second challenge we find when we do the TVS is if the gynecologist is male or if the infertility doctor is a male doctor, then there will be lot of hindrance, lot of resistance by the woman to undergo the ultrasound scanning. At that time, it is always preferable to have a nurse well trained to put the probe into the vagina and cover the entire thigh and the legs because she will be in the lithotomy position with a cloth, the preferably a bedspread, a white bedspread, so that our organs are not seen by the attending male doctor. And the probe can be easily maneuvered by the attending nurse. Of course, you can just guide her what to do by holding the nurse's hand, so up and down. And ultimately, once you gain the confidence of the doctor, the patient, you can hold the transducer by yourself. And another thing is, because of so many medical legal problems, it is mandatory to have a lady nurse when the person doing the transvaginal scanning is a male person, either a radiologist or a gynecologist or an infertility doctor. If the doctor is male, it is mandatory to have the a female attendant by the side, because of the medical legal problems she may face, because she may scream when you put the probe, and when she may shout, and the people outside the chamber may mistake that something is going on inside. Because if the girl is the lady is not consummated, that is, if the hymen is intact, you may not be able to introduce the probe. And another thing is, in case of unconsummated marriage, if the vagina is tight and if the hymen is not ruptured, it is always better to counsel the lady that your hymen is not ruptured, or if the vagina is very tight, we will dilate a little bit with a small dilator or a small vibrator. Put ultrasound gel, lignocaine gel, dilate it, and postpone the TVS scanning for day or two. And once she is comfortable, then only her to do. That is, dilatation of the vagina is important by using lignocaine gel and a dilator or a vibrator. Otherwise, she will start screaming, shouting, and blood may come, and she may be annoyed. So these are some of the challenges we've come across before while doing the transvaginal scanning. Another problem is the congenital anomalies of the vagina itself. Vagina itself may not be fully developed, or it may be very tight hymen, so that is impossible to penetrate the hymen. Such cases, there will be congenital abnormalities of the vagina. The vagina itself may not be developed. At that time, it's always better to go for an MRI scan to find out the genital anomalies of the uterus, cervix, and the vagina. So that is genetical anomalies. Another problem is, when there are lot of the small intestine around the ovaries, we may not be able to trace the ovaries at all, in spite of going near. At that time, what would have happened is, the ovaries would have become abdominal organs, because lot of bloating of the small intestines will be there around the uterus, and the ovaries will be hardly seen. At that time, again, it is better to go for an abdominal scanning, and along with the transvaginal scanning. And very streaky ovaries, underdeveloped ovaries, it is very difficult to pick up the ovaries in the scanning. And lot of malformations of the uterus, sometimes it will be difficult to assess the uterus also. So these are the challenges we see in our day-to-day experience. So 1 in 10 will have problem in doing the scanning. And even doing, when we are doing the egg retrieval by transvaginal ultrasound scanning, we find difficulties. Over to you, Feroz.
Thank you so much, sir, for sharing your personal experience, and I hope that this will be going to help all the participant and the Dr. Subramaniam also who asked this question, sir. Moving forward, I can see another question from Dr. Snehali. She is asking,
Yeah.
are there any emerging ethical issues related to the use of transvaginal scanning in infertility diagnosis? What's your point of view on this, sir?
No, there are no ethical issues. Only thing is, the legal complication is, if the male is doing the TVS scanning, the presence of a female attendant is a must, because how we are directly going and touching the internal organ, the genital organs. So a lot of complications may come. That's why it's always better to, and also, if the doctor is a male doctor, it is better to take informal consent, that explain the lady that we are going to put the probe into inside you. Only if she agrees, you have to perform the examination.
Thank you so much again, sir, for sharing the enlights on this question, sir. We will be taking one last question from Dr.
Sure.
Ankita Sengupta, and she's asking, are there any specific patient population or condition for which transvaginal scanning may be pose challenges or require special consideration?
Can you please repeat the question?
The question is that
Ah, hello. Hello.
Yes, sir, I'm repeating the question, sir. Are
Yeah, yeah.
there
Please
any
repeat.
specific patient population or condition for which transvaginal scanning maybe poses challenges or require any special consideration?
Yeah, that's what I told you. Congenital anomalies of the vagina is a special challenge, and lot of for the bowel, that is small bowel around the ovaries, around the uterus. It is almost impossible to locate the ovaries, and yeah, anomalies in the fallopian tubes and ovaries, and sometimes ovaries will be abdominal organs because the fallopian tubes will be floating and they would have become abdominal in nature. And because the transvaginal scanning can only see up to say something like 6 to 12 centimeter, beyond that we are unable to see. So huge fibroids, the ovaries which are floating in the abdomen, which have become non pelvic organs, you may not be able to see. And lot of gas around the ovaries also, it is very difficult to locate the ovaries. And streaky ovaries, underdeveloped ovaries, hypoplastic ovaries, you cannot see. All those things have to be done by abdominal scanning or go for an MRI scan.
Thank you so much, sir, for answering all the doubts of the participant. As I can see, no more questions. And Dr.
Nice.
Ankita has written,
Yeah.
thanks for the response and answering my
Thank you,
question.
Ankita. Thank you so much. I'm so enlightened by your questions, and also very happy to be part of IJCP. They are doing human service, bringing all of us together to share our knowledge and enrich our knowledge in different fields. So, thank you, all the authorities of IJCP, and also thanks for us for moderating and undergoing
Welcome, sir.
all the tortures of delaying in this lecture. Thank you.
No problem, sir. Like as we know that if there is a perfect platform where the healthcare knowledge is shared, it will be beneficial to the population in the entire country, sir. And it is
Yeah.
really very glad to have doctors like you on our platform, sir. As
Thank
there
you.
is
It's
no
our
more questions, sir. Yes, sir. As there is no more questions, shall we conclude this session for
Why?
today?
Sure, sure. Okay.
Bye,
Good
sir.
night.
Take
Shubha.
care, and we will catch you again with different
Oh,
topics, sir, in
sure, sure,
future,
sure.
sir.
Okay. Okay.
Bye, sir.
Thank you.
Take care.
Good
Good
night.
night.
Good